Okay. Good evening, everyone. So welcome to the HTCA, which is Houston Taiwanese Clinician Association summer webinar today. So my name is Ryan Wei, and I'm the current first-year psychiatry resident in Elmhurst Hospital in New York City. So I'll be moderating today's discussion, and we are joined by our wonderful panelists here. So we have Dr. Sun, who is the attending psychiatrist, and Dr. Chen, who is the second-year psychiatry resident. And also we have our Shekinah Wu, and she is our counselor in Texas. So I also want to thank our event organizers, Dr. Lee and Dr. Ma, for making this event possible. So today's webinar is designed for students, trainees, and anyone who is curious about mental health care. And we will cover a wide range of topics related to mental health professionals, and hopefully we can give you a better understanding of what a career in mental health care can look like. So if you have any questions during the webinar, please feel free to drop a message in the chat. And we can go through the questions during our Q&A sessions. So to start, could each panelist briefly introduce yourself, your training background, and current work? So I would like to first invite our attending psychiatrist here. So Dr. Sun, please.
Sure. Hello, everyone. I'm Dr. Sun, or welcome to Chin. I use any pronouns or they name. So I graduated from China Medical University in Taichung, Taiwan, and then came to the US, did my general psychiatry residency at Virginia Tech Korean Clinic. And after that, I did a child and adolescent psychiatry fellowship at University of Washington and Seattle, Georgia. And I just graduated, which is yes, I'm so happy. Yeah. And moving forward, I'm going to be attending psychiatrist in Manteca with a clinic called MyPath. And also, I am the assistant professor as a volunteer faculty for Virginia Tech at this point as well. Next person.
Okay, thank you, Dr. Sun. So here we have Dr. Chen.
Hello, everyone. I'm currently a second-year psychiatry student with a background in medicine, public health, and law. I'm passionate about destigmatizing mental health care and improving mental health literacy. Very excited and looking forward to today's discussion and the opportunity to learn from everybody. And thank you for HTCA's invitation.
I'm sorry, Dr. Chen, I have like a little bit hard time to hear you clearly. So is it possible for you to maybe adjust your headphone or microphone a little bit? Okay. Okay, and then
Sorry for that.
Yeah.
Do I need to
Yeah, it sounds better right now.
introduce again or
Oh yes, please.
okay, sorry for that. I think my microphone is not working. Yeah, so thank you for HTCA's invitation and very excited to today's discussion. And looking forward to learning from everybody. I'm Yawen, and I'm a second-year psychiatry resident at Brigham and Women's Hospital with a background in medicine, public health, and law. Passionate about destigmatizing mental health care and improving mental health literacy. Thank you, everybody, joining us today.
Thank you, Dr. Chen. So now we have Shekinah, please.
Hi, everyone. Thank you so much for all of you being here. It's a Friday night in the United States. And it will be a Saturday morning for you if you're in Taiwan or anywhere in other countries. So thank you so much for being here. My name is Shekinah U. I'm the licensed professional counselor here in Texas State. And right now I work as a career counselor educator in Texas State University. I was a counselor in a juvenile services before. So thank you so much for having me. I'm so excited for today.
Yeah, thank you everyone. So yeah, let's get started. So to set a stage, I would like to begin with why mental health care matters so much right now. So as we know, there's been a rise in therapy talk and the use of psychiatric terms on the social media. So Dr. Sun, from your perspective, like what mental health concerns are you seeing most often in the USS right now?
Sure. So from my perspective, like in practice, I would say mood disorders still being very popular, like depression, anxiety, and also I think this is kind of different from Taiwan, that we see a lot of substance use, like especially marijuana, alcohol, or other kind of substance. Yeah. And also, I think a lot of people doesn't really understand that we see a wide range of conditions. We also see people having difficulty sleeping, or seeing kids who cannot pay attention, or have some developmental delay, like autism or other kind of neurodiversity kids.
Yes. So yeah, I think I would like to piggyback on the from your answer. So you mentioned there's like a substance use concern in the States. Do you see any differences in Taiwan, like than the States?
Yeah, to be honest, I don't have much experience exposed to the substance use population in Taiwan, but per my experience in internship, I only see kind of 1 or 2 people have alcohol use disorder. Well, when I came to US, it was a big shock because I feel like most of our patients have certain kind of substance use situation in the inpatient side. I would say that at least 50%. Yeah. And outpatient is less, but still very prevalent.
Yeah, thanks for your brief introduction about mental health. So now I would like to move on to our next section. So understanding mental health professionals and collaborative work. So I think for many people, I guess as students or for the general public, the mental health system can be really confusing. So when we hear words like psychiatrist, psychologist, therapist, counselor, or even social worker, but people may not know how these roles differ or how they work together. So Dr. San, so what is the maybe clearest way to explain the difference between a psychiatrist and a psychologist? Dr. San, you're on mute.
Okay, yeah, I got it. Yeah. So the easiest way to tell between a psychiatrist and a psychologist or therapist is if they're involving in prescribing medicine. I would say this is the easiest way. So psychologists and therapists, they are specialized in therapy or assessment, psychological testing, while psychiatrists, we graduate from medical school. So we have to go through all the comprehensive medical training, internal medicine, surgery, OB-GYN, everything, and then specialize in psychiatry. So all the psychiatrists, we have a doctoral degree, while psychologists, therapists, they are more diverse background, but they don't do prescription, and that is the underlying difference.
Okay, so Shekinah, could you help us to explain the difference between a therapist, counselor, and social worker, and what do these professionals usually help with in real world settings?
Yeah, and this is just based on my experiences because I'm pretty sure they're like different, people, they do different things. So I feel therapist is an umbrella term, right? Anyone who see people like one-on-one, sometimes our patient, our client just call us therapist. The main difference between counselor and social worker in Texas, so every state they have different requirements. So check your state. If you're in different country, check your country's policies and laws to make sure. In Texas, if you want to become a counselor, you can be a LPC, which is licensed professional counselor, or you can be a LMFT, which is licensed marriage family therapist. Or for a social worker, for you need to earn an LCSW, licensed clinical social worker. But basically, they can, all of them, like all the license I talk about, they can provide one-on-one therapy session for your client. In the format you want, you can do one-on-one, you can do group therapy, you can do family session, you can do couple session, and the setting might look different. Like me, I work in university. You can also work for like private clinic, hospital. I feel the main difference between counselor and social work, I think social worker, they see people from a bigger perspective. Maybe they have a, bigger picture about the historical, cultural, community resources, maybe gender identity. They pull in a lot of resources when they see clients. For most of the counselor, I think we usually use like more like about the strengths already in the individual, and then we're more like support you, like we want to go along this journey with you and see how we can solve this difficulty together. It's like we're just like holding your hand and then going through this journey. Does that make sense?
Yeah, absolutely. So, yeah, and I also feel like as a maybe as a social workers, it also matters a lot for families and patients as well because they can gather a lot of informations and a lot of resources for patients and their families. So it's definitely like a very stellar role in mental health care. So, and now I would like to bring in a clinical vignette to help the audience understand how multidisciplinary care works for a patient suffering from mental health conditions. So imagine there is a 20-year-old college student named Alex, and Alex is a sophomore and who has been doing well academically and being active in multiple student-led activities. But over the past 2 months, Alex has become increasingly withdrawn, and he stopped going to book club and missed a few classes and deadlines, and would just stay in her room and lay in bed for days. So his roommate noticed that Alex has been quite edgy recently and saying things like, "I feel like I'm falling behind, and I don't think anything will get better." So one evening, like Alex sends a message to a close friend and saying, "I wish I could just sleep and not wake up." And the friend becomes worried and walks Alex to the college counseling center the next morning. So I think this case shows how a student may first present in a college counseling setting, but he may need different levels of support depending on the assessment from the counselors. So, Shekinah, if Alice came to a college counseling center, what would the counselor's first steps be? How would you assess Alex?
Yeah, we have like, suicidal ideation assessment. Usually in our counseling center in our university, if there's like immediate like danger in the session, we will contact the law enforcement really quickly because, we just don't want anything happen to the student. So sounds like this is a pretty like extreme and severe case. Most of the student, if they stay in their dorm and they don't want to go out and they don't go to class, usually they activate like, dean of student and then UPD first, like University Police Department first. They will go there to like knock on their door to make sure they're fine. So I think if they can still come to counseling center, usually it's not, as severe as the worst case scenario. But for this one, if it's like we assess them and if it's like immediate like needs, we will contact the law enforcement. And then the law enforcement will take our student to the hospitals.
Yeah, just like Shekinah say, so sometimes maybe students are not that severe enough and they can still walk themselves to the counseling center, but maybe sometimes if a student has been suffering from really severe suicidal ideation and already do something to themselves, so it might be better for themselves or for a family to maybe call the ambulance or take them to hospital. So it is just a 2 cents on my end. So let's keep on walking through this case. So Shekinah, so I'm also curious, so what kinds of question would you ask to understand suicidal thoughts?
Yeah, in counseling, there are like, ways to identify. I think there are like 4 different steps. I think you need to like make do they have this like intention, right? Have they mentioned about I don't wanna, wake up, right? And then in a counseling session, usually we ask really, verbally, we will ask like, do you wanna kill yourself? A lot of people have like this myth if we ask that, would it reinforce the thinking and feeling they want to kill themselves? Actually, it is not. Yeah. We just want to make sure, do they thinking about this when they say, I really don't want to wake up? What does that mean? Right? Does that mean like I don't want to face tomorrow exam just for one day? Or does that mean, I really don't want to live on this world anymore? So that's like huge difference. So, and then after you make sure they have this intention, maybe you ask, do you have previous attempts? Maybe they say, maybe if they say, no, I just sometimes think about it. And the last time I thought about it is like years ago, right? Then that's like, oh, that's not in immediate danger right now. But if they say, actually, I tried yesterday, I took a lot of pills, and I hope after I take like 10 pills, I will never wake up. Then that's, that's something very, immediate needs. We need to take some action. And then we also assess from like the means. If they say they want to take pills to end their life, do they have the pill with them right now? Right? Did they take them with them in the session? Are they going to do that in the session? That's like super, super immediate danger. Usually we have a button in our room. Sorry, I cannot show my face. There is like a desk and usually there is a button. We can just like quickly press that button and then that will activate the UPD and then activate the law enforcement. So you, you yeah, when smile. Yeah, I think, when we walk to the stage, you can explain more. So my role is usually push that button, and then I will hand the student to, the following colleagues I have. Yeah. So I saw a student before they have the means with them. That means the way they want to end themselves, they bring that to the session. So that's like we have to do something. That's like our number one rule. If or they say I took the pill when I come to here, right? That's something you need to do something immediately. So I don't like to see the law enforcement or UPD take away my student, but it's just by the university policy that this is something we have to do. I hope this answer your question.
Yeah, totally. Yeah, and you also like bring up a really important point that so we know psychiatrists and also counselors are meant to help patients, but if a counselor or a psychiatrist experience a patient might harm themselves or even like harm the therapist, harm the counselor or psychiatrist at the moment during the interview. So it is really important for a counselor or a psychiatrist to protect themselves and also protect the safety of the patient, to push the button to and activate the following process and also to ask for help from other staff. Yeah, so thank you for mentioning that. So the next question I would like to ask Dr. Chen. So if there was a concern for Alex's safety and he is subsequently referred to the hospital, so what would crisis intervention look like?
So if Alex is referred to the hospital, um, if the school counselor thinks that it's unsafe for Alex to go home, usually the counselor would section. In Massachusetts, we call it section, meaning that Alex cannot leave leave voluntarily. and he needs to be evaluated in the emergency room in a hospital. And so Alex would need to stay in the emergency room until a psychiatrist come to see him and then decided that he's safe to go home. And for the crisis intervention, usually we will, have a full evaluation of the patient. The first step is the emergency room doctor would see Alex or other patients have the similar crisis, and then decide whether they need to call a psychiatrist. Most of the time, if the emergency room doctor feel confident to see, to decide themselves, they may not call psychiatrist. But most of the time, if it's related to like suicidal ideation or very clear sectionable cases, they will call psychiatrists. And a psychiatrist will evaluate the patient and decide what kind of intervention, what kind of medication that we want to prescribe to help the patient feel better at the moment. When we make that decision, we will, ask questions, a lot of questions Shekinah has been talked about. So we will evaluate whether patient is safe to themselves or safe to others, has a danger to themselves or danger to others, and whether it's safe for them to go home. And during that process, we will make decision whether it's safe for them to go home. It may go through different days, and if we think it's not safe for them to go home, we will section them, and that means we will start bed search, and they will be put on a list for inpatient psychiatric unit bed search. Excuse me. And during that process, we will ask questions, but also see whether there are other people that we can call for. So, for example, their family members or their outpatient providers, their psychiatrists or therapists that who know them better than us. Because when we evaluate them when they are in crisis, we only see a snapshot. So it's better for us to get collateral information from family members and providers who know them better, like a longitudinal understanding of them, because sometimes they may have like suicidal ideation for a very long time, or they may have suicidal gestures or suicidal threats, but they usually don't. They may make those threats and gestures a couple times, but they may not really have real danger to themselves. But sometimes they may say something vague, but they have extreme danger to themselves. It's totally different from their baseline. So it's really helpful for us to get the correlateral information.
Yeah, thank you, Dr. Chen. So yeah, I think it's a really comprehensive explanation of what psychiatrists do in the emergency setting. So usually psychiatrists have to do the full safety evaluation to see if patient is safe enough to go home, or they have to stay in the hospital for maybe medication or therapy treatment. And Dr. Chen, can you further explain what inpatient admission is meant to do and how Alex can benefit from inpatient admission?
Sure. Yeah, so in inpatient psychiatry unit, there are a lot of benefits. First, Alex or any patients will be evaluated by a team of psychiatrists, therapists, occupational therapists, and social workers. So it will be a team make a comprehensive decision and treatment for you. And also there you will be in a confined environment. So if you have addiction or you have suicidal ideation like Alex, then it's helpful for you to be evaluated and be away from any substance that can affect your decision making. And so sometimes just by being in a place that there will be no safety concern, like no knives, no wires that, sometimes people know that they have suicidal ideation. They know it would be helpful for them to be away from wires or pills, because when they see those things, it triggers them to want to do something harmful to themselves. And also, social workers will help to set up your aftercare plan. So if you want to see a psychiatrist or a therapist, but you don't have any means or insurance, the social worker will also help you set up those things. But I want to point out one thing, which is, I think is super important, is that inpatient hospitalization is not the only mean to do those things. So we have different levels of care: inpatient hospitalization, partial hospital, intensive outpatient program. Of course, I understand that it's different in different states, but in Massachusetts, we have different levels of care. So the psychiatrist evaluating you will make that decision with the patient together to decide what is best for the patient. Of course, if there's a urgent need and we have an urgent concern for the patient, we may decide to section the patient and may not, respect, or we will of course respect patient's decision, but we will need to section you because we really worry about you. But if we think you haven't met the section criteria, then we may work through the differences of different levels of care and make that decision with you. So for partial hospital is like a 5 days a week program for 1 to 2 weeks, and intensive outpatient program is a 3 days a week program and lasts for 4 to 8 weeks, depends on your symptoms and your progress. And if you have works, you can also do intensive outpatient program at the evenings and then not affecting your work. So there are many different choices, and there are many different benefits that you can get from different levels of care, different levels of psychiatric care.
Hey, yeah, thank you, Dr. Cheng. So yeah, so inpatient psychiatry might sound kind of scary for most of the people, but actually people who has to be hospitalized, actually they can do a lot of things during inpatient stay. So there are group activities and therapists out there. So actually it's really a good time for patients to get back to their daily routine or to set up a future goal. So, and also like as Dr. Chen mentioned, there are multiple layers for patients to reach out to after discharge from inpatient settings. So there are actually a lot of safety net for patients suffering from mental health illness. So yeah, thank you, Dr. Chen. So next, so Dr. Sun, I would like to ask, after Alex is discharged to a student clinic, what would outpatient psychiatrist follow-up look like?
Sure. So after a patient discharge, like as mentioned by Dr. Chen, there are lots of paths, and we are only one of the possible paths that as a disposition plan. Yeah. But if patients consider stable enough, they come back to us. So if I never see this patient, like this is a totally new patient from inpatient, then I will still do the comprehensive intake, like all the assessment needed, like family history, past history, and do my own diagnosis clarification. And also, very important, that I will try to understand what happened before the hospitalization. Like what was the trigger, like what was this young people like go through that make him so stressful, or what are things going wrong in his life. Yeah. And then the process of hospitalization, like during the hospitalization, what has been done. Like did anyone adjust medication, or they started therapy, or he has complete certain kind of program group, that I want to know this kind of detail. And also, I would want to talk to the inpatient team if possible. Because a lot of time, the inpatient team will have information that we don't have. Like, as we see patients for long term, but we only see them when they're in clinic. While the inpatient team, they monitor patient 24 hours. So they are the team have more comprehensive observation for the short term, but continuous data. And other than these two parts, like understanding hospitalization and the whole assessment, I would also want to do the safety assessment again. Yeah. So that is exactly the thing she kind of mentioned in the very beginning, like thought, intention, plan, like, is this a reliable, practical plan? I would like to know. Because for me, like when patient discharge outpatient, I cannot assume they're stable. I still want to ensure that everything's good. And of course, after, like, theoretically, there should be a plan in place upon discharge, like refer to therapy or to us or to kind of resource. But still, if in the process of diagnosis or in the process of clarification, I found the patient still have some unmet need, then I will still do the referral, like to therapist, to social worker, or even to other specialty if the patient has some medical need. Yeah. And also, just kind of piggyback on the previous discussion, if you pay attention to the previous contents, you will feel like, oh, why psychiatrist is everywhere? Like psychiatrist in the emergency room, and psychiatrist in the inpatient, psychiatrist in the outpatient. And to do a brief explanation, yep, psychiatrist has a lot of roles in different kind of stage of patient care. And also, we had a lot of different work to do as well. Like some people are more lent to the inpatient care and they're okay with the taking calls and see patient night. And some people more lent to outpatient care, like only see patient as needed or as appointment. But we have a lot of different kind of working style.
Thank you, Dr. Sun. Yeah, that's very fascinating to hear the mental health care from the student clinic as a first step, and then hospitalized and the following outpatient follow-up. So it's really a chain. We say like there is a chain of survival for patients who lost of consciousness or who had a heart attack, but actually this is kind of a chain of survival for patients suffering from mental health as well. So Shekinah, I would like to follow up. So after Alex is connected to psychiatry and primary care, and he is back to school. So what else can the counselor continue to provide?
Yeah, at my university, we see student bi-weekly, and I know this is not enough. So we do have another like care team. They're more like the case manager role. Usually social workers, they're in this process. They will introduce a lot of like community resources. Maybe they are like private practice out there. They can provide maybe like sliding scales. That means you pay the each therapy session based on your financial status, right? So they're like sliding scale as low as like just $20 per session. So student, they can come to our counseling center bi-weekly. And if they need more assistance, we can pull in more community services, resources for them. And yeah, I think that's pretty much a university what we can do. Oh, we do have a student health center, and we do have a psychiatry in the student health center. We only have one. So she's really busy, just like Dr. San talked about. They're everywhere and they're super busy. I can vouch for that. I used to work for juvenile, and we have one psychiatry for the whole juvenile as well.
Yeah, so we all know that like college student is a really like essential period of time within the lifespan. So we know it's really stressed during college time. So Shekinah, do you also have any like maybe practice or like skills to do with the college students as well in school?
Yeah, so every counselor use different theory orientation. I'm a person center. I know it's really hard to understand. Basically, I believe you're just like a plant. If I give you the right sun and soil and water, you will be fine. I believe in you. You will just grow. You have the inner strength. And I'm just like there to, support you, not necessarily guide you because I just want to be there with you. That's pretty much my theory, but there are multiple different theory. I know for if you have like severe bipolar, maybe CBT, right? So they have different approach or trauma, then you use EMDR. So different like theory orientation, different technique and skill. We do have one counselor in a university setting. They train to use EMDR, but that's not a guarantee for every setting. When I was in juvenile, every of our counselor trained with EMDR. They pay for us to get that training so we can use that because that's a really trauma based residential institution. It's like inpatient, but we use residential institution in Texas. Yeah, and right now I'm seeing more college student. That's a very different population compared to the juvenile. So right now I don't use EMDR anymore. I use person center. We do have a lot of like assessment tool we can use in the counseling center. So you need to get trained to do the assessment with student too. I use a lot of basic skill. So basic skill means just the basic counseling skill, like active listening, paraphrasing, reflect your feeling, reflect the meaning. For example, if you say, I just feel so, upset I got B for this class. Or I don't know what to do for my future. I don't even know why I study pre-med. And now the chemistry is so hard. Something like that. And then we basically, use our basic skill, always like, paraphrasing. I heard that you say you feel it's really difficult to navigate the college experience and normalized, it's really hard to navigate. For example, if they're a first-gen student, you can add that. It's really hard to navigate. It's really brave for you to come in and seek out for help and come to college and try to finish the college. So that's basically how the counseling works in a really, small pick. Yeah, yeah. And I do have a lot of students, they want solution. But counseling, we don't necessarily provide solution for every of your life questions. I believe all the solution it's already in them. So I will prefer ask them, what are the things you can do to, make things a little bit better? Or I will use like miracle question. What if you are really good at chemistry? You're really good at everything else. What you want to do, where you see yourself in the next 5 years. And maybe that give them a little bit like imagination and hope for like their future. And once they have that activate in their mind, maybe it's not going to work for everybody, but maybe they can set a goal for themselves and maybe we can set up baby steps to the next achievable small goals. And then we check in bi-weekly. Yeah, I hope that answers the question. This is a really big question.
Yeah, thank you for that. So, thank you for the clinical pearls and your experiences working with students. So, to wrap up this case, so Dr. Song, could you briefly summarize how the multidisciplinary team works together in a case like this? Like, who will be involved?
Sure. So, like quick cap of what happened. So in this case, the first line will be the school counselor, like do a safety assessment and decide if this kid need to be sent to emergency room or not. And in this case, it's determined yes, so the kid is sent to emergency room. And in the emergency room, there will be psychiatrists involved and also the emergency room doctor as well. And then if the kid is determined to be sent to inpatient care, then they will have a whole multidiscipline team. And that will become a psychiatrist, a therapist, and social worker, and nursing staff. And after discharge, there will be multiple resources available. And for the part to outpatient care, then it will be mostly psychiatrists. But still, there might be therapists and social worker involved as well. So the team is kind of like continuation. Like it's not block by block. It's a process of a lot of people involved. And also one last piece of the story that I just want to put out there is, if the patient stabilizes enough, there is a possibility that we will discharge them back to their primary care provider. Like they can continue to get the medication from the PCP while continuing to do the therapy with therapist. So that's the cap of the story.
Yeah, thank you for a really quick recap of our discussion. So now let's move on to the training and career pathways. So many students are interested in mental health careers, but they may not know how long training takes or what the pathway looks like. So Dr. San, could you walk us through the general training path to become a psychiatrist in the United States, like from medical school to residency and possible fellowship?
Mm-hmm. Sure. So to begin with, there are two different paths. First is for people do medical school in Taiwan. The second is people do medical school in US. That's kind of different. So for people do their medical school in Taiwan, they will have to take the medical exam for the US, the USMLE, and then come to US do a residency. And for people who are in the US, they like this kind of USMLE application has been a part of their path, so they don't need to take an extra step. But for people not in the US, there will be a lot of different things have to be done. And requirement, like in addition to the radio medical school, people had to figure out at least 3 months of so-called USC or United States clinical experience, which can be an internship or clerkship or even being a observer, like those kind of things. And medical school usually don't support that, so that's kind of thing that you have to figure out yourself. Like, yeah, you can choose a rotation like a board, so that's kind of opportunity people can use. And also you have to get letter of recommendation, and especially from doctor in the US. So you can imagine that you want to get a letter from someone just know you for 1 month, then you must be very impressive. Yeah. So that's about that. And also the application itself is a big hurdle because there are time difference to arrange the interview logistic, to take a flight, book the hotel, and also all sort of thing. I think Ryan probably still have a lot of memory about that. Still, a lot of thought. Yeah, probably he can share as well. But anyway, after that, if you match a residency, that's great. Then basically you're good for now. And for the people who do the medical school in the US, it's a little bit different. Actually, the story was different from the very beginning. So in Taiwan, people graduate from high school and do medical school. But in the US, people graduate from high school and do a college. That will be a 4-year thing. And then, oh, by the way, that has to be, it include one thing we so-called pre-med. So college, 4 years, and then 4 years of medical school, and then apply to residency. So it's a little bit more straightforward, like don't need to worry about USMLE, like or worry about rotations, but still it's a long path and stressful. Yeah. And after you match a general psychiatry residency, actually you can start to think, what do you want to do in the future? For many people, they're kind of like, I just want to do psychiatry, and let's see. So they just get in and have fun and look see what they want to do. Well, some people, they already have an idea, like I must be a child psychiatrist. I must be a specialist in forensic psychiatry. Then they can plan ahead as well. And also there are some path which is more interesting, like combined path. And actually, I do have a slide. Let me try to see if I can share so you can have a better idea about how this works. All right, can you see my screen? Okay.
Yeah.
Okay. So here is a layout of general psychiatry residency program. First is 4 years. That usually is 4 years. That you go through all the rotations and learn basic psychiatry. And then for people who want to specialize in subspecialty, they do a 1 to 2 year fellowship. And here I list some pretty common fellowship people can choose, but also there are more. Like child psychiatry, addiction medicine, forensic psychiatry, or even sleep medicine is a part of us. And there are some alternative paths I mentioned, like a combined path. Like people can combine internal medicine, psychiatry, which I think is super intensive. I will absolutely not do, but some people do. And I think they're super cool, by the way. And also you can combine family medicine, psychiatry if you're interested in more kind of working in primary care setting. And also this one is very cool as well, like pediatric, general psychiatry, and child psychiatry, like triple board, super, super cool. Yeah. Of course, very intense as well. There are the pros and cons. And psychiatry, neurology, for those who always got the first place on their exam, just kidding, for most smartest people. But anyway, and neurology, internal medicine, this is kind of interesting as well, like combine, and then plus on psychiatry. I don't know how they did it, but anyway, they did it. And post-pediatric portal pathway, this is a special thing. So this group of people, they do their pediatric residency and then do psychiatry. And here is an example for child psychiatry. And you can see here, like all kind of path. Like for example, for me, what I did is we so-called a fast track, which means I do 3 years of general psychiatry residency. Well, my last year, like I skipped the last year of general psychiatry residency, but directly go into child psychiatry. So a regular 6-year program for me become 5 years, which is great. And also there are some child track, fast track. Oh, this is yeah, this is me. I did this one, fast track, and triple board, the super cool one. And also there are some kind of more special track that give people more opportunity to do research as well. You can see like here, there's some research component. And then probably you will be wondering, what do people do during the residency? So here is the ACGN requirement for psychiatry residency. And you can see here, like blocks. A block means 4 weeks, like it's not 1 month. It's a 4 week, 4 year, 4 week or 4 week thing. So inpatient, outpatient, very basic. However, we still have to learn the basic medicine, so that's primary care. Yeah. And neurology, like we do have very solid neurology rotation as well, like working with a true neurologist. Yeah. And also child psychiatry as a part of regular training, CO psychiatry, geriatric addiction, and emergency psychiatry. So here is a outlier. And actually, there's still some kind of block is not included here, which is so-called elective, which means you can do whatever you like. Yeah. And some programs offer research opportunity, and some programs like offer like interventional psychiatry, which people can do ECT or TMS, like those big machine put on people, and so a lot of things. And here are other requirement, like for me, like for example, my program, for example, you have to observe at least 10 ECT, which means when patient getting this procedure, you have to stand by it to watch what happened. Yeah, you don't need to do it. And also pass 3 CSV. And this is fun. Like this is kind of like you interview a patient while attending physician like stand by you and look at you and not talking, being very weird. And you have to have a grade to see if you have enough skills to pass. Yeah. And also scholarly activity, it really depends. Yeah. Most programs pretty chill about scholarly activity. You don't need to publish a paper to graduate. That's the underline. But you have to have certain activity. And also some programs have provided this kind of opportunity to be a sub-attending, which is cool. And some people have some program to offer like CBT, psychodynamic, supportive, like all this kind of like, I would say wrap-around training. Yeah. And for scholar activity listed over here, but anyway, I think it's not a big hurdle, even though they sound scary for some people. Yep, I think that's the sure from my part.
Yeah, thank you, Dr. Sun, for the slides as well. So yeah, as you can see, so it takes quite a while to become a psychiatrist, and let alone Dr. Sun is already a child and adolescent psychiatry. So 6 years of medical school and 5 years of training. So it takes 11 years to become a child and adolescent psychiatrist. That's really a long journey, but it's very rewarding as well. So as Dr. Sun mentioned, so a lot of Taiwanese medical student or even like international medical graduate, they do additional rotations in the States in order to get into residency here. So, and also there are like different pathway, like some of them might pursue additional degrees like Master of Public Health, for example, in the States, and then to gain more connections and gain more experiences, then enter residency. So that's also one of the paths. So like, speaking of MPH and additional path, I would like to ask Dr. Chen. So, as we know, you have a really interesting and very fascinating background as a MD, MPH, and also JD. So, could you share a little bit about your path?
Sure. And I think Dr. San summarized a very comprehensive training for psychiatrist training. So it's very, very exciting. For me, I am a research track resident. So basically similar to what Dr. San was talking about, basically 4 years general psychiatry training. But also I have more elective time. So similar to what what they were talking about, there will be mostly inpatient psychiatric training in the first 2 years, and then more and more outpatient training in the third and fourth year. But for us, we have more elective time to do research. My program is very supportive, so we can also do clinical elective, but those elective is meant for us to do research, but we can combine clinical and research if we want to. And for me, I went to school of public health, learn public health, and then do research. Do research for a couple of years, and then went to law school and become a resident because my interest was in ethics and though ethics about involuntary admission. So I'm curious about, because I think most of the time in other care, we provide care and they don't really question whether this is beneficial or not. But when we do something involuntarily, sometimes people may think about whether this is the best interest for the patient or whether that's aligned with what the patient wants. So I think it's interesting. And also there are very different laws and policies in different states. Some states like Massachusetts cares about patients' autonomy or liberty more than providing care. So they would mostly make sure that the patient is really want to have that care before really giving the treatment. So for example, in our inpatient unit, we need to go through the court and have the judge make the decision, have both sides, the lawyer from the hospital and the lawyer from the patient, to make that decision before the patient get the medication. In making sure patients' autonomy, this is really good. But for other states, they think it would affect their timely treatment. So it's always pros and cons and a balance between liberty and safety of the patient and also for the public. So for me, that's why have different training, and that's my path. If you are interested, I can talk more about that.
Yeah, thank you so much. So, yeah, so as Dr. Chang say, judges and court hearing also plays a role in psychiatric care for patients. So if sometimes like patients, there are like admitted to inpatient setting, like involuntarily, they might also like have their own lawyer to file maybe a court hearing, appeals, to make sure they also have right to fight for their own wish. So that's a really important thing. And also, like in the United States, there are like different laws in different states. So that's another topics we can discuss for quite a long time. So let's save it for next time maybe. Yeah, but that's really interesting. And Shekinah, so could you walk us through the training path to become a counselor or LPC in the United States?
Yeah. Only in Texas, I cannot talk about, how to be a counselor for other states. I think it's quite similar because I would suggest you go to a CACREP program. So the CACREP, you go to the website and search what university and program is accredited by CACREP. That means, I think that means you can take the NCE National Counselor exam while you're still a graduate student. So it will be, faster for you to get the initial license. So basically, you need to graduate from the undergraduate. It doesn't matter if you graduate in Taiwan or you graduate in United States or any other country. And if you want to become a counselor in the United States, you want to apply to a graduate program. And that I suggest CACREP accredited, so that you don't need to wait for like several months after you graduate to take the NCE. So CACREP program, and then usually it's at least 3-year program. I say at least because a lot of my peers they need more time to graduate, so it's normal and common. And don't give yourself more grace if that happened to you. That's okay, and that's also true for your medical school journey. I learned so much today. I feel like this is, so amazing. Like how many years of training and how many years of learning and finally become a doctor. So yeah, sorry. So 3 years. The first year, maybe like first 1.5 year, you're pretty much like learning in the classroom, and then you will practice with your peers, like role play, you recording yourself, recording others, give other people feedback. We do a lot of training. So I did a lot of training with expressive arts. So we use a lot of arts in the counseling session, like Centray for trauma, Centray for kids, right? They don't know what substance abuse means. They don't have the language yet, but they know what that looks like in a Centray setting. So they can demonstrate it in front of us. Like this is how their parent do in the house. So basically that's when we notice there's something happening and maybe we should take more action. I got a lot of training for that. If you're interested in like a specialization, I would say most of the counseling program provide you the general education for being a counselor. If you want to become more specialized in a certain area, for example, you want to be a play therapist, or you want to be like a trauma informed counselor, or like the EMDR I talk about, or animal assist therapy, right? If you have an animal and then you want to take them into your session, so they be a therapy dog or cat, I think you can still prepare early by just researching the program. Make sure the program has the population and the focus, the needs you need, so that you don't need to go to another institution, pay like fees to get more workshop and then more certification done. So, or you just research the faculty to make sure you have some faculty that align with their career interests. But again, people can change your mind. If you change your mind, that's okay. You can still explore, what population you want to work with. And then after you finish all the class component, you will go to an internship component. It's like we have like practicum and then internship. So maybe every state they have their different names, but basically you will start with like just maybe 3 clients. I remember my first semester seeing client, I just have 1 client, and then my professor hold hand in hand with me. So basically I need to record myself, and then I need to, transcribe everything I say to think of if there's better response. How can I, better support the clients? And then I have like peers, they will write feedback for me. So first semester, 1 client, and then second semester, 3 client. And then they will push you to do an internship that's like 120 hours per semester. That's pretty much your full-time job in 1 semester. Because you will have client no-show, which is really normal. Again, don't blame yourself if they no-show or they never book another appointment with you. That's not your fault. It's not because you're a bad therapist or a bad doctor. No. And then you survive 2 semesters of internship, and if you got all the hours, then you graduate. But between the counseling program, you need to take 2 tests, 2 exam, national exam to get the license. So in the middle of your program, if you don't pass that, then you cannot continue the program. So it's really sad. I think there are some steps, gatekeeping in the medical program maybe. So in the middle of the program, you take it, and then after you are close to the end of your program, you take another national test again. Then you have your first initial license, is called LPCA, Licensed Professional Counselor Associate. Then you need to earn postgraduate hours for 1,500 hours. That's usually 2 to 3 years. Good news is you don't get paid in internship, but you get paid once you graduate as an LPCA. So you're not a student anymore. Yeah, and that's where I am now. I'm like 400 hours close to the 1,500. Yeah, I'm almost done and I can get my full license.
Yeah, you're almost there. So hang there. Yeah. So as Dr. San, Dr. Ching, and Shekinah said, so it takes years and thousands of hours to become a licensed counselors and also a psychiatrist. So you have to enjoy and have fun and work hard. So I think that's the model for everyone interested in mental health career. And Dr. Chen, so could you briefly tell us what does a typical day look like for a psychiatry resident?
Sure. So honestly, we in our training every several weeks we will change our rotation. So for example, in the first year we have, so that's why day to day, a typical day will be different depending on what rotation you are in. So for example, in the first year, we have a half year of service rotation. So we have to go through 4 years of internal medicine training and 2 years, so 4 months of internal medicine and 2 months of neurology. That's what Dr. Song was talking about. And so the day-to-day life would be similar to internal medicine or neurology resident. And then after you finish the off-service rotation, you will go through inpatient psychiatry unit or emergency psychiatry or addiction, geriatric, or TMS in the first year, or geriatric in the first year. And then for second year, of course, every program is different, but for our program, this is like that. And for second year, we have 2 months of child and adolescent psychiatry, another 3 months of inpatient psychiatry training, and then 2 months of consultation liaison psychiatry, which is like get consult from doctors in the hospital. So if a patient admitted in the surgery or medicine unit and they have a psychiatric question, they can consult us. And then 2, 3, and also 1 month of community psychiatry. For us, it's a state psychiatry. And also for me, I have another 3 months of research time. And for the third and fourth year, third year is subspecialty clinics. So you have women's mental health or neuropsychiatry or you can choose to do oncology or like specialty like IBD, psychiatry. Um, and then for second year, we have one afternoon to do outpatient psychiatry. So if you still do the inpatient thing if you're having an inpatient rotation, but on the Tuesday, like for example, Tuesday afternoon, in the morning, you still go treating the patient in inpatient unit, and then in the afternoon, you see outpatient patients in the clinic. And the fourth year is mostly electives. So for a typical day, if you are in an inpatient psychiatry unit, it looks like in around 7 or 8, you go to the hospital and you look at what happened to the patient yesterday or last night, what kind of medication like PI or medication that needs to be given for the patient. Maybe they have some acute crisis last night, or something happened medically. You want to see that, and then you get sign off from the doctor, your colleague last night, to see what happened, and then see whether there are new patients in your team today, and then you go to run patients with the attendings and maybe medical students, and then you have a multidisciplinary team meeting with all the other members, the nursing and OT, social worker, and psychologists and everybody. And then if it's necessary, you will consult other specialties. You will talk to the patient again to clarify certain things, or you will talk to their outpatient providers or talk to their family members to update them or to get some information that you need. And then meanwhile, there may be other patients admitted to your team, and then you will need to take that patients, and then you do those things in the afternoon, and then you go home. And if you have clinic, then you most of the time you want to do those things as quick as possible, and then you go to the clinic in the afternoon.
I thought you were going to say as quick as possible so I can go home.
Yeah, so our own well-being is also very important. So just don't work over hours and just do more self-care. So that's really important. So Shekinah, can you like briefly walk us through how is a typical day for a counselor?
Mm-hmm. Yes, I agree. Don't burn out. Everyone, don't burn out. Practice self-care. So as a LPC, I have the privilege to schedule, to organize my own calendar. So I have a maximum of 4 clients every day. Each of them, I block 1 hour for them. So usually most of the counseling session run 15 minutes, right? So I will have 10 minutes to run to the restaurant if I need to, or like water break, stuff like that. So usually I have like 2 clients in the morning. I process that and then have a lunch and then 2 clients in the afternoon, process with client, and then I get to go home. That's typical day, but some days we need to do like group, right? It's not every day. Some days we need to do group, then you have 1.5 hour doing group. Sometimes you need to present like psychological education, psychology education. How can I say that? You need to provide workshops to like talk about what does mental health look like for a college student. So you get the chance to like do different jobs as a counselor. Yeah.
Yeah, that sounds really nice. Yeah, so you give us a lot of hope what a psychiatrist's life or a counselor's life can look like after graduation, after becoming a licensed independent therapist. So yeah, that's the that's the upside as a mental health care provider. So now I would like to move on to our last section. So what is a life as a mental health professional? So we all know that this field can be really meaningful because you help a lot of people, but it can be also like very emotionally demanding because you have to deal with a lot of negative emotions, or sometimes patients really been through a lot of terrible things, and you have to deal with it. So a topic that is very important but sometimes not discussed really openly is the boundaries. So Dr. San and Dr. Chang, I would like to ask, how do psychiatrists maintain boundaries with patients? Yeah.
Should I go first?
Yeah.
Sure. So for me, I think recognizing the importance of boundary itself is the first step of maintaining boundary. Because a lot of time people feel kind of like slip through a boundary. It's always like coming from something good. But on the other hand, actually, if we really want to help the patient, maintaining good boundary is the right way to do it. So if people have like too much emotion, kind of entangled with the cases and kind of crossing the boundary, then there are a lot like potential trouble or harm can be done. Like there could be legal issue and there could be like adverse issue, or that can muffle your diagnosis tools or can make you less accurately like assess the situation, or like putting too much your self-image on the patient, like the so-called projection, then that can disturb the therapy relationship as well. So I think just think about the upside and downside of maintaining a boundary. That itself is the first step. And also about the boundary, I think understand what is boundary is also very important to maintain a boundary. Yeah, because I like this person and I like this person to a degree that is not appropriate. It's pretty different thing. Yeah. So for psychiatry, it's especially tricky because we were told to like our patient. Like it's a part of our job. Like no matter how much these people come to the clinic is disliked by everyone, whatever they did, how annoying they are, like we always find something in them to like them. So that's very important. And based on that, we got to determine what is the line, where is the line. Like very appealing case is like if a psychiatrist like can provide free food and provide free things to patient, is that boundary crossing and boundary violation? And probably not, yeah. But also, if that keep happening, then something worse can happen. And so we always try to have an official way to provide help, other than giving patient this kind of we so-called favor, but actually not good. And I can also share some horrible story that I heard. Like, I heard one of my classmates, unfortunately, like have some issue with patient because he brought the patient to the call room privately. So that was the kind of, oh no. Like whenever we heard this kind of story, we was like thinking like, how could this happen? Like this is ridiculous. Or a patient like write a love letter to a doctor and doctor write it back and then have some relationship outside the therapy. We heard that story happen, like between doctors, between therapists, and it's kind of shocking. But every those severe situations start with a very small slip while not able to maintain the boundary. So I would say understanding the boundary and recognize the importance of boundary are the first step. All right, now the other turn.
I think Dr. Sun gives a very comprehensive talk about boundary. I want to talk about normalizing having therapy or therapist or psychiatrist for ourselves. So it's pretty common and normal to have therapists or psychiatrist for us. So it's totally fine. You get routine, care for yourself as well. Or also other things like if you like yoga or other things, whatever you feel beneficial for you, please make sure to do those things. And boundaries is important. At the same time, I think it's also important for us to debrief as a group for providers. So for example, Dr. Song talked about hating the patient. So I think it's pretty normal to feel a certain feeling to a patient. We call it countertransference. So sometimes it's related to, maybe you see the patient and that reminds you something in your past. And there might be certain reasons why you feel more emotion towards certain patients. So it's good to work this out with either your providers, or your colleagues. Then you know why this happened. In our program, we have a Friday noon conference time. So sometimes we will talk about these topics like how to hate your patient, seems like that. Why, or, we will talk about why why this happened and how do you deal with this. And also like difficult patients, difficult situations, or, some negative outcomes happen. We always debrief as a group. So I think those processes are also important to maintain your career, like maintain the awareness of your mind.
Yeah, so as many patients we've seen in clinical settings, so we all know not every patient is polite to you. So sometimes they can be really rude, or they like pass down some kind of emotions or his or her like past experiences onto you. So that's what we call transference. So they pass their own feelings with someone they really hate or they have like a bad experiences with, and then they put this strong emotion toward their therapist or toward their psychiatrist. So just like Dr. Chan say, usually we'll have a debrief to talk about these kind of strong emotion like you're feeling with your supervisor, either like psychiatrist attending or either our psychology supervisor. So it can be like really helpful, and also talk to your co-residents, your colleagues. That will also be really meaningful to help you better understand yourself. And Shekinah, can you also maybe share your experiences, how to maintain boundaries or how you maintain your own mental health well-being?
Yeah, I 100% agree what Dr. San just shared. Like when the clients start to give you a gift, that's something's going on. And then being a counselor, if you are going to be a therapist or a counselor once in your whole career journey, you will have a client fall in love with you for sure. Because, when you're looking for a partner, you're looking for someone who listen to you, who support you, right? Who like you, right? If you have somebody listen to you every week, it's just really easy for you to feel like, oh my God, I build like a special connection with my therapist. I really want to know, am I the favorite one? Am I your favorite client? They will ask questions like, am I your favorite client? So that's called dual relationship in our, counseling. If you ever form other type of relationship with your client, not in a professional way. For example, if you be friend with them. So right now, I cannot counsel everyone here in this room because now I know you. I cannot be your counselor now. So, we cannot be our friend's counselor. We cannot be friend with you if you're our client. We cannot have like, of course, romantic relationship with you. So that's like boundary. For me, another boundary I'm still working on is just professional boundary. I don't want to take my client home. So that means like I don't want them to stick with me. I think about my client when I first started this job. For example, if I have client have suicidal ideation during the session today, but I already made a safety plan. I already took the action I can I can take. But back home, I would still think about him, think about them, right? I would still thinking like, what if tomorrow they don't show up? What if what if their friend contact me? What if tomorrow I go to the campus and then something happened, right? So I feel that's something I'm still working on. Sometimes I still worry about my client, even if I'm at home. So I encourage everyone, this is something you can work on. But sometimes it's, for obvious good reason. You care about your client. That's fine. But just try to have your own life out of your work. That's my way to do self-care. Have your own life. It's okay to have fun, right? It's okay to have fun after work. It's okay you have a family. It's okay you adopt a cat, like whatever you want to do. I crochet every day. I can show you my crochet project. I crochet every day. So get something to do, like you truly feel like happy. I think that would be helpful for a lot of our self-care.
Wait, I just really want to piggyback, right? It's kind of funny. Like a lot of people want to go into psychiatry or psychology, completely forget that they are also human with needs. Like you're allowed to have fun after you get off of work. Like that's kind of a very basic thing. That's kind of highly resume for my experience from medical school. Yeah. And also the other thing kind of like mentioned by Shikaina that kind of resonate a lot is understand the limit, like safety plans in place, we go home, this is done, work is off. Like this is so important that I think it took me so long to figure this out. Like stop thinking, right? And also taking care of ourselves is actually taking care of the patient as well. If we are not presenting ourselves in a healthy and also stable, like mind, then actually we would not be able to provide the best care we can. Yeah. And from the other aspect of this is for people who always worry about other patient and worry that if their patient is going to die or something, it's actually a part of that is based on the assumption that if I'm good enough, then my patient would not die. Or if I did enough, then my patient would survive, which is completely not true. Like those are things that we cannot control. Yeah. And even there is a part of therapy, like kind of psychological, like family say something like provider cannot expect themselves as able to do anything. We so-called a kind of grandiose thought or grandiose stand. like it's not what we are going to do. We are going to admit that we are also human. There are limits and things happen no matter what. So that part of boundary and self-care, pretty important thing to know.
Yeah, so honestly, like mental health providers often carry the weight of our carry the weight of life for our patients because you are really important for them, especially when they like go through crisis in their lives. And I also want to cite one of Dr. Sang's work. So there is like a statistic data showing that psychiatrists is actually has one of the highest suicide rate among all the specialty in medicine. So I think that's really important for everyone in mental health care to also care and love about yourself. So I think that's why we choose psychiatry, and we want to care people we love and also care ourselves. Yeah, so I think I'm kind of have like a random question for you also. As a mental health provider, so usually I think it happens a lot like in our daily life, maybe our friends or our family members say ask us if we can do like therapy for them, like to psychotherapy or any kind of therapy. So what do you think? How would you respond to your family or your friend if they ask this from you?
Are you going to pay me? Or just kidding?
Oh, usually I say no. I would just explain the ethic to them. So Dr. Chen, learn about ethic and law. So it's counsel ethic. We cannot provide counseling to our friends and family. That's dual relationship. So I would just say, sorry, even if you want to pay me, I cannot be your counselor. Find somebody else. I can refer you to my colleagues, something like that.
Yeah, I think this is like a big shock for a lot of people that it's actually generally not advised to provide therapy to friends and family. I think there are a lot of reasons. One major reason is the relationship can be different. So being a therapist should be neutral, and you are a therapist, so you provide care to the patient. And there are certain words or certain things that you would talk to your therapist, or your patients may not talk to your friends, vice versa. Certain words and things you will talk to your friends and you won't talk to your therapist. And and also in therapy, there is a group of people think that being a therapist, your job is to let the patient know themselves, to reflect what the patients really think, and to reflect themselves. So you want to project as little as possible as you as a therapist. And also you don't want the patient know too much about you because of that. So that's also related to the boundary topic we talked about. And the more you know about the patient, or the patient know more about you, then that would cause more biases. At the same time, you want to build a relationship with the patient and the therapist. Like you want to build the relationship with the patient. So it's kind of tricky to hold that balance. Like you want to build a relationship, and then that the patient trusts you and give you more information, but then you want to hold the information from yourself to the patient. So it's kind of an art to be a therapist, or providing therapy care to the patient, or psychiatric care.
Yeah, yeah, thank you guys so much. So, yeah, I think it's really important to to let your family or your friends know we cannot provide like psychotherapy for you, unfortunately, because we know each other, we have so much like overlap in our life. So that's what like Shakana say, like that's what we call a dual relationship. It's gonna cause bias toward each other. So it will be less beneficial for you to do this with with someone you know. And I also want to ask like a follow-up question. So we all know like therapy nowadays, like it's not uncommon for the public. But I really want to ask your opinion, like what kind is everyone okay to do psychotherapy, or do I have to wait till like I have certain symptoms, or I become like really serious and have suicidal thoughts, then I can seek help from therapist?
Can I answer this question first?
Yeah,
Um,
sure.
so as a counselor, because I'm a counselor, I hope you just use counseling just like you're doing like massage for your body, right? When you feel like tight in your body, you do massage to like release the tense and you feel relaxed. You feel like you're a new person again, right? I think counseling works like that too, right? Every now and then you need counseling to talk about it. I usually recommend you don't wait until you know maybe you don't want to go out, you don't want to go out of your bed, or you cannot fall asleep for like several days or months, or your friend noticing that you're not hanging out with them anymore. So there is a lot of like signs, right? So because I'm a counselor, I usually recommend you just come see us if your insurance allow, right? If your company provide you good insurance, usually you can see counselors sometimes for free for a few sessions. then just use it. Use it. It's free. Then you just see us like doing massage. I think you will feel like mentally or you're feeling or like just like let us like process that with you. And I think you will feel just like lighter. If you carry something really heavy, right? You will feel more lighter in this process. Yeah. But I don't know if that's true for the medical field.
I'm totally agree with Shakina. I think sometimes you don't really know what happened to you. A lot of times we have strong emotion or we fastly react to certain things because of things that we don't really recognize. And a therapist or a counselor is the one who will be a neutral position and be able to help you see through what happened to you. So I agree that if you feel you may maybe just like come to your mind or you're just curious, it's totally okay to seek a counselor or therapist and maybe just help you see what kind of need you have. It would be great. For psychiatric care, I think like in terms of medication, I think it's also nice to talk to a psychiatrist and see whether you need that medication or not, and or maybe you are taking medication and see what kind of adjustment that you can have. So I think it's always a good idea that you go to ask and then seek out help if you feel you need it.
Yeah, I basically agree with Dr. Chen and Shikaina on this topic. And I want to provide some additional information about like the indication therapy, let's call that. So about the evaluation, I would say mostly what actually happened is patient go see a therapist first. And if needed, then refer to psychiatry. So because it's kind of hard to see us anyway. Yeah. And about the necessity, and I would say I totally agree that having an evaluation won't hurt. And also I know there were people being kind of worried, oh, what if like I was underdiagnosed or overdiagnosed or the therapy had never been ended? Therapists want to see me because they need money or they want to get client. Yeah, I know people can have that worry. And there's a joke saying that for therapists, there's no normal people. There's only people underdiagnosed. Okay, that's a joke, yeah. But I know it's a lot of people's worry. And also, I can ensure that it's actually not true. Okay, so for therapists and psychiatrists, when we do evaluation, we have a very clear line about who need what. Like this person has a like psychopathology going on. If this is something severe, needed more evaluation, or this is something we so-called stress related, or environmental factor, or situational, if those are kind of very clear picture, like this is situational, like when the stress is gone, then this person should be fair, should be okay. Then we would not send this person to emergency room, would not refer them to psychiatry. Like this will be just one-time evaluation and kind of provide like reassurance, like, hey, this is difficult, and we also see that you're having a hard time. Let's do psychotherapy first and not medication, or if you want to wait and talk to your family and friend, have some support, and then come back follow up 6 months later if you still feel you need it. That's actually something would happen if we feel like this is not a true psychopathology, or we think the psychopathology is not severe to a level not need to be taking medication or do long-term short-term therapy. And the second part to this answer, like the indication therapy, I would say there's a common myth that people have severe cognitive deficit, or people who are not able to communicate or able to comprehend the idea of therapy cannot do the therapy, which is partially true. But a lot of times people kind of like over expect someone's capacity to participate. Like we can do therapy for people with schizophrenia, like to help them, assist them to adjust hallucination or delusion. We can do therapy with elderly with dementia, just more kind of coping skills and also support. And we can do therapy with very small kids, like young kid, 4-year-old, 5-year-old, like play therapy or exposure therapy, a lot of things we can do. And even with people with disability that they have very limited cognitive, probably like traumatic brain injury that have a hard time to express or receive information, we can still having some social model to help them. So I would say, is this patient appropriate to do therapy? Having a therapist or a psychiatrist to do a comprehensive evaluation is the answer. So just go see them anyway. That would be my recommendation.
Yeah, thank you all so much for walking us through the full landscape of psychotherapy and psychiatric medication management. So the reason I brought up this question is that I want to raise awareness that you don't have to be so serious or so severe to a point for you to seek help from mental health providers. So there are a lot of like different practices within psychotherapy. So you will find a modality that really fits you and they really help you to grow. So yeah, that's really important for you to potentially find your own therapist in the future. So that would benefit a lot. So yeah, so I think time flies. So now we are almost at the end of our discussion today. So before we move to the audience Q&A, I really want to say something. So I think psychiatry and psychology is a really fascinating field. So psychiatry is just an umbrella term. So as our panelist mentions today, so we have a lot of subspecialties to explore. So if you are interested in field of psychiatry or psychology, you can always find your own strengths and your own interests. So I think that's really important. So now I would like to ask each of our panelists one closing question. So what advice would you give to our audience who are interested in mental health careers? So maybe start with Dr. Sun.
Sure. So for people who is interested in pursue career in mental health, let me see. Honest advice, talk to someone already in the field. One thing I found very beneficial is talking to a real psychiatrist and a real therapist or a real psychologist. And actually, I did that when I was in high school. Like, there's always kind of like career development, like work or something. I somehow managed to find a psychiatrist willing to talk to someone who is not going to see them as a patient. So I think that is very helpful experience. Like he was kind of surprised, like why this student just come to my clinic? Yeah, but that conversation was very important. Like give me a better idea about what he's doing, like what is that actually looks like. And also, I talked to a psychologist at school when I was in high school. Like probably she kind of 20 years before version. Like, yeah, I think that experience was kind of like inspiring as well. Like to hear like firsthand information, like hear the like, because now we're just chatting like in public, so we can say like kind of private thought about things, but when you're talking to them one-to-one, they will tell you a lot of things that you should know before you choose this kind of area or to feel as a life commitment.
Yeah, and Dr. Chen, do you have any advice?
I agree with Dr. Sun. And also, I think it's important to talk to as many people as possible because just like we were talking about, even a psychiatrist, you have different lifestyles, different career paths. So if you only talk to one person, you may not like the work that the person does, but you may like the other type of working. So just very quick example, outpatient or inpatient. You may not like outpatient, but you like inpatient or vice versa. So I think it's important to seek advice for from different people. And also if you can, shadow them or watch YouTube video about what does it look like as a psychiatrist or mental health workers, and then you kind of have a basic understanding of what their life look like. Because sometimes you may like a certain part of the career, but you actually hate a big part of the life. And also I think it's important or useful for you to list what is like the most important thing for you when choosing a career, and why do you like this career, and what is a big no for you. And sometimes it's about the content of the career, but sometimes it's about the lifestyle of the career. So I think it's also important to separate that out, because maybe you like the content but you don't like the lifestyle, or vice versa. So that's the advice that I would give.
Okay, it's my turn.
Yeah,
Yeah.
absolutely.
So I specialize in career counseling. I'm so happy to hear, you talk about that's called informational interview. Everybody here in this room, now you know the secret. Go on LinkedIn or any platform you use and then DM someone. The worst scenario is they say no. If 1 out of like 10 say yes, then you know more from a certain career. I think that's super beneficial. That's just a bigger term for networking, but that's a really practical way, right? You DM somebody or you find a family friend and you know more about career. If you are one of my client, I will send you like a information interview question you can ask. So my general advice is you create your own question list. Like, what's your day-to-day life look like? What's the part you like the most for this career? The least favorite part for this career? What are the trends? Things like that. And yeah, and feel free, I will put my LinkedIn in the chat. Feel free to connect with me. Even though I cannot really provide counseling for you, but if you want to ask question about anything, I can answer. I can just give you like quick answer or have a quick interview if you want to do an information interview to understand my career. I can do that. That's okay. That's not counseling session. Yeah. And then I think we have a question in the chat, right? Should we answer that?
Yeah, sure. So, yeah, we are now like entering our Q&A session. So, um, one last reminder. So, don't ever shy away from asking questions. So, everyone could be your mentor and could be your help. So, just feel free to reach out to us or any of them. So we'll open the floor for audience to ask question. And now we have one question in the chat. So, okay, let me say it. So, is it common for mental health professionals to seek therapy themselves? So if so, are there any unique aspects to providing therapy for another mental health professionals? Does the shared professional knowledge create challenges or advantages? So what do you think?
Oh, I have so many stories. You go first. You go first. You go first.
So just speaking from the counseling perspective, we do have counselors, they specialize seeing medical professionals. That's their specialization. So if you need therapy or a counseling session, you can find a counselor, they specialize in that. I have a friend who actually specialized in that, and she been through the whole medical program and then finished the residency, and then she decided to study counselor, mastered again, and then become a counselor. So yeah, I would say for me, I believe if I experience something you experience, that creates more empathy in me. So I know what you're trying to going through. However, some perspective out there, they might say like we should be really careful to posting our own bias, right? Because the things works out for the counselor ourselves might not work out for our client. So I can see that it's a double-edged sword. But usually it's like a delicate dance in a session. You practice years and you training for years, you will know more about the boundary. Not it's about their time. This is their session, their therapy. So make more room, make more time to like listen to them and let them find their own steps and solution instead of you telling them, oh, have you done this before? You should consider that. That usually will not work well in the session.
Oh, is it story time?
Yeah,
Oh.
let's do it.
Okay, so I can share one of my super weird experience. Then when I was in residency, that I had during the inpatient rotation, we had a patient with alcohol use disorder. I'm going to change some demography over here so we don't expose like violate HIPAA. But anyway, so this is a middle-aged woman came, and when I was talking to her, I got the sense that, oh, this is kind of weird, you know? Like I feel like I'm not asking question. Why these questions are so fluent? Like just coming back and I get all the information. And I said, what do you do for a living? And she say, I'm a senior psychologist. And I was like, oh no. And that happened when I was in the first year of residency. And that was about the first few months when I started the residency. So basically, I knew nothing. Well, she knew everything. So that was the most awkward experience I ever had. And I even nowadays, I believe she took pity on me because I was so nervous. Yeah. But anyway, I got my senior to see the patient again with me. And my senior was a third-year resident. And things got much better, apparently. And in the end, she asked, like, how does it feel like for you being here, like being also a mental health professional? And she was very honest. She said, it's awkward. And we just laughed. Yeah. So that was when I was in first year of residency. And later on, I have zero experience about like seeing other kind of like kind of mental health, like social worker or like their family or but and I feel like for me, my experience is if your client or patient is also working mental health field, the one thing helpful is to make the session conversational. Like, because if you are telling them like, hey, this is skill I'm to teach you, and they'll probably tell you that I know that skill, or yeah. So make the session conversational, more human-like, make real relationship, make the professional connection also peer-to-peer relation. I mean, it's kind of challenging or picky or tricky. Like we don't want to do a dual relationship, but also we don't want to pretend that we didn't see the truth. So I think that's one thought I have with time. And the other part of the question I think is probably even more important is, do we do therapy for ourselves? The answer is yes. And actually, I will be one of the persons strongly advocate that all the people do therapy or psychiatrists should do their own therapy because there are just so many things need to be processed and need to understand. And if someone say that I'm just going to prescribe medicine and see a patient 15 minutes and buy, then probably no. But for somebody like dedicating therapy, almost like see patient like for the 15 minute, 45-minute session and want to use the skill, then I think it's important because it will help us to reflect like what are the materials from us, what are the material from the patient. When we are talking to the patient, having the feeling, is this a feeling from the patient or a feeling from us? Like, or is our stance neutral? Like, are we giving an objective observation, or are we giving a neutral reflection? Like, not mixing with our own thoughts, no memory, or our own. I won't call it contamination, but I would say our own subjective truth, other than the truth of the patient. Yeah. So I think that's kind of important. And actually, historically, therapy used to be a part of mandatory requirement for residency, that all the residents has to do their own therapy in the program, and which was taken away in a certain year, especially after the psychoanalysis or psychodynamic therapy trend, like kind of like getting pushed away by more kind of modern like like structural therapy like CBT, DBT, but I think the concept is still very valuable.
I think both Shekinah and Dr. Song give a very comprehensive information about this question. I just want to add a couple of things. First, if you are interested in this topic about whether therapists have therapy themselves, you can read a book called Maybe You Should Talk to Someone. It's a very good book about this topic.
I have that book. It's really good. I have the
Yeah,
English
second
version
that.
and the Chinese version.
Yeah, very interesting, very funny book. And the other thing I want to highlight is that I think it's normal for people, even mental health workers, become sick sometimes, and sometimes the severity of your illness, no matter you are in like severe depression, severe depression or acute mania or acute psychosis, can affect your cognition. So it's normal that you seek help when you need to. So, I feel it may be a challenging for you because if you are a mental health worker, you may know the concept and you may think that you should be able to take care of yourself, but then you get sick. Maybe, that will be important for your providers to identify that and then give medication or therapy. Usually when in acute crisis, you will need medication first, and then you can get therapy. But my main point is just that it's normal. Even if you are a healthcare worker, you can get sick sometimes and need your providers.
Yeah, thank you all for sharing that. So I think we still have some questions. So let's end for ending our discussion today by maybe 9:05 Central Time today. Okay, so the next question is like, have psychiatrists or counselor yourself try to improve your communication skills during your career training? I think there is one related question from our audience is that what is the biggest challenge you facing as a bilingual mental health professional in the States? So how would you say that?
Language is definitely, right, something very difficult. But once you practice more and more and more, I think you'll be fine. But being a counselor, I think language is like really important. So how I improve my communication skill, practice with peers, make American friends. Or whatever country, if you're going to like France, then make a friend in they speak French, right? So make a friend and then talk with them. um yeah, the biggest challenge, it's not language for me, it might be language for other people. I think the biggest challenge for me, I take the client issue back to at home. So that's my biggest challenge so far.
About the communication skill and language issue, I think the question is actually two layer. The first layer is the ability in language, and which I would say is what super, super hard for me the first few months. It was a huge struggle. Yeah, but after that hurdle, everything become fine. And the other thing is, people will be surprised that about the bar, like how low it is to practice psychiatry, or I won't say therapy, but for psychiatry at least. I think it's not to speak perfect English, but to be good enough to understand people or to be understood. If you could understand other, if you could be understood, then that's good enough. Okay. And the second layer about communication is skill. Yeah. So even you have perfect language, if you say something stupid constantly, it's probably not a good idea. Yeah. And to answer your question, I do see the long question over there. I would say if you're asking me to point out one single thing that is easy to do, easy to learn, and also immediate effective, I would say learn active listening. That would be my short answer for the question.
Agree with both. I think it's not just language. Of course, language is one issue, but um, there are also cultural differences and also communication skill. So, for example, there are certain type of problems or issue or needs in different countries, in different generations, in different backgrounds. So it's important to expose yourself to different cultural background or country background so that you kind of understand. So I don't think it's necessary for you to need to experience those, but yourself, but you want to be diverse in that sense. You want to be open-minded. And communication skills, what I mean is that a lot of time patient may not talk to you about their real feeling in the first place. So how do you get those information you need, and also, showing care for the patient, especially when they have acute crisis, they may feel afraid to expose too much information to you and being sectioned or being think as like freak or something. So they may not tell you the truth. And how do you get those information and at the same time you want to get the information you want and need to assess safety risk, but you don't want them to make the patient feel you don't care about what they are talking about, because sometimes patients really want to talk about certain topic and in really long length but not answering your other questions. How do you navigate those situations is also important.
Yeah, I think it's a process of unlearn and relearn. So just be modest to learn from your patients, from your coworkers, and to be sincerely interested in their story. So you'll be able to learn how to speak in their own language and understand their culture. Yeah. So yeah, the next question is for a psychiatrist, what does the lifestyle look like, and how often would you have on-call duties? What is the ratio of inpatient and outpatient duties? I saw Dr. San share some schedule here, but Dr. Chen, Dr. Shekinah, do you have any insights? Okay, Dr. Chen?
Yeah, I think Dr. Sun is very comprehensive in this topic.
Yeah, so yeah, I think we have like different schedules for different years. So like for third year psych resident, you have whole year like outpatient learning, and after graduation, it depends on what kind of working environment you want to keep on working. So you can basically choose on your own, and it also depends on whether you work in a hospital or work in a private clinic. So yeah, that varies a lot. Okay, so the next question is, what is the biggest challenges you have seen in clinical settings that you wish it could be addressed?
Insurance.
So true. Ah,
Yeah, that's the point. Yeah, Dr. San, go ahead.
No, it's just one of the US frustration that I've been experiencing. Like in Taiwan, we have nationwide insurance systems, so people just take it for granted. But in the US, like your claim can be denied, and you have to call the insurance company, and then call the patient, and then call the pharmacy, and no one know what is going on, but the patient can get a prescription. And I feel like so much time is wasted on dealing with the insurance related issue. So that's a big thing I want to put over there.
yes, and the endless paperwork.
Yeah, so I think that's related to our next question. So like in United States, there are a lot of underserved areas. So we know there is often like a long wait list for patients to receive mental health care. And also there is a crowding in the ER. So what do you think of the situation, and how do you think we can target that situation?
Oh, I really want to share about one of my study I did in 2022 to assess the US mental health care availability. And in the study, we found that less than 20% of outpatient psychiatrists are accepting new patients. And also the average waiting time for in-person visit was about 67 days, while for the televisit was 43 days. So that is kind of shocking number. That was back in 2022. And also the study was done like based on people with insurance, private insurance. Like so, but things have been changed. And recently, what I saw more common is telepsychiatry is much more accessible than in-person visit. And also there are a lot of kind of like telehealth company like Psychiatry, MyPath, and also kind of Doc something, like there are so many. So I just kind of randomly browsing their website. I saw so impressive. Like the wait time is kind of a couple of days, or like today is Friday, probably they will be opening on next Monday. So it's kind of really different these days. So I would encourage like people take the chance to seek all sort of resource. And I'm not going to say if in person or virtual, like which is better, which is worse. I would say there's all downside and upside. So, but if nothing's available, then I think telehealth is a current solution for things.
Yeah, thank you, Dr. Sun. So I think here comes the end of our discussion. So let's ask one last question. So any advice for a pre-med or the first year medical student interested in psychiatry?
Maybe Dr. Chen go first.
I feel we kind of talked about that in our closing advice. Similarly, so I would say if you are interested in psychiatry or mental health care, it's best that you talk to people or can observe or do volunteer works, or similarly, networking with people on LinkedIn or stuff like that. Get exposed to as many different people as possible, and then so that you know what psychiatrist or therapist work look like.
Yeah, Dr. Sun, do you have any like additional insights or anything you want to add?
Additional insight, I think Dr. Chen has to do a very nice like cap about what we discussed. And I would just say to all of you, thank you for being here. And also for pre-med student and whoever's interested in this career, no matter your decision, like no matter you decide to join us or not, I wish you a best life and have fun.
Yeah, thank you so much. I think that's a really lit conclusion. So yeah, like what I said, so feel free to reach out to any one of us if you are interested in field of mental health, and also seize every opportunity to ask help from everyone you know. The worst situation is to get declined from someone, but it won't hurt and you'll get used to it. So yeah, thank you everyone for being here today, for like accompanying us with a 2-hour session. So really appreciate that. So if you have any feedback, please let us know. And have a good night. Thank you so much.
Any additional questions for us?
Yeah, do we have anything to discuss, or like is Kevin still here, or I'm
I think
not
Kevin
sure.
left.
Okay, yeah, so yeah, maybe we'll discuss it on the chat on Facebook.
Hey.
So
All right,
Yeah.
so nice to have this webinar with all of
Yeah.
you. Thank you so much.
Thank
Yeah,
you,
Bye.
thank you so
everyone.
much.
I learned a
Oh.
lot from
Oh
you.
yeah, I learned a lot as well.
The
Yeah.
medical
thank
school
Likewise.
journey. Wow.
Yeah, that's really impressive. Yeah, thank you so much. So yeah, let's stay in touch. Thank you.
Bye.
Bye.
Bye. Bye.